Hello, my name is Forest Heis, and I am giving a talk today on common knee injuries. Just a little bit about me. I am from the area. I grew up in Anderson Township and then went to Stanford University out in California, came back to UC Med School, and then did my orthopedic residency at Duke before going to Salt Lake City for a sports fellowship during the Olympics. I'm a partner at OrthoCincy. I'm the chairman of the Orthopaedic Institute at St. Elizabeth that's putting on this series, and I've been team physician at Northern Kentucky University for the past 19 years. So with any type of knee injury, our first concern is getting things calmed down. Many of you heard about RICE, rest, ice, compression, and elevation. The first thing that you need to do when you injure your knee is to get off it. When a knee is injured, it starts having an inflammatory response. So that's where ice comes in. Now, it's important to ice fairly quickly, especially in the first 48 hours, but to do so intermittently. We recommend 20 minutes on and 40 minutes off. That allows for the skin to recover so you don't get frostbite. Compression is also important. Again, we're trying to get rid of inflammation. So that is something that helps keep the inflammation from expanding through the joint. And then elevation, the same thing. Gravity works for you. So if you can get it elevated above your heart, that allows the inflammation to work its way out. So common knee injuries, the most common knee injury is probably a straight contusion. Now that can happen when you get a direct blow, and it can go all the way down to bone. On the left, we see an MRI which shows some swelling, or that white is in the bone. That's edema. That'll generally heal on its own. Obviously, things can be a lot worse. If you look at the middle picture, that's a kneecap that is broken into 4 pieces. Those type things often require surgery. And that's what we see on the right. It's a tension band technique to put all those bones back together. Tendon injuries are also very common. The tendons around the knee, there are 2 main tendons. The quadriceps tendon, which attaches the 4 muscles of the quadriceps into the top of the kneecap, and then the patellar tendon, which is actually a ligament that connects the kneecap to the tibia. Now, a couple things can happen here. You can have a partial tear where just some of the fibers tear. When that happens, oftentimes we can treat that with just rehab and time. A full rupture, though, especially in the front of the knee, makes it so you can't extend your knee at all. When that happens, we often have to operate. So here we see a diagram of a quadriceps tendon rupture. So all 4 muscles of the quadriceps come together at the top of the kneecap. When that tears, it often pulls off of the kneecap. Now, tendon will heal back to bone very nicely. It just has to be next to the bone. And what happens is, since the tendon is attached to muscle, it tends to pull away. So that happens in the knee. It also happens in your rotator cuff and your shoulder. So if we bring it back down to bone, though, it will heal. In the middle picture, you can see where we drill holes in the bone and then sew the tendon back down to the bone. Again, as long as the tendon's next to the bone, it will eventually heal. Now, I'm giving you a warning ahead of time. This is where a hamstring gets pulled off. So it's a little bit higher than the knee, but a hamstring can pull off of your ischial tuberosity, or the bone that you sit on. And it causes a lot of bleeding like this and can give you a funny looking muscle in the back. The way we repair that is by reattaching it. Now the next picture is an intraoperative picture showing what it looks like. So here you can see that in between the 2 retractors there, that there's the tendon, and then you can see the heavy duty suture that it takes to bring that back down to the bone so that it'll heal. All right, getting back to the knee and getting away from all the blood. On the inside of the knee, there are 2 shock-absorbing cartilages called your meniscus. You have a medial meniscus on the inside of the knee and a lateral meniscus on the outside of the knee. Here you can see the bone on top and below the meniscus, and then that fuzzy-looking thing in between is the meniscus. There are basically 2 ways to fix or repair a meniscus. Commonly, after the age 40 or so, you have a tear on the inner edge of the meniscus. So if we see in the upper left-hand corner, that meniscus has suffered a flap tear. Now, there's no tourniquet up or anything like this, and you don't see any blood. And in the body, blood is important. That's how things heal. So when you have a tear where there's no blood supply, it won't heal. When that happens, we just remove the part that's torn, leaving all the good meniscus behind, and we can see that in the bottom left picture. On the right, if the tear is toward the blood supply, and you can see just a hint of pink in there, we can actually repair it. And there I sewed the meniscus back together. One other thing about this is the rehab is different. I know we have another talk on rehab of knee injuries, is when we remove part of the meniscus, it's bad that you don't have the same shock absorption as you did when you were younger, but I'm removing the problem. So you can get back on it and get moving on it more quickly. When we repair something, it takes a little longer. You're on crutches longer, but you get to maintain all of your meniscus. Now, ligaments. The ligaments are the one thing that no athlete wants to deal with in the knee, primarily because we all know about the anterior cruciate ligament, or the ACL. But there are actually 4 ligaments about the knee that all can get injured. The ACL, the PCL, the posterior cruciate ligament, which is right behind the ACL, the medial collateral ligament, or what's listed here as the tibial collateral ligament, and then the lateral collateral ligament on the outside of the fibular collateral ligament. Now, the ACL is unusual in that it only has one blood supply. So when it gets ruptured, it can't heal. The other ligaments have more blood supply and can heal with just bracing and rehab. The PCL is very unique in that an isolated PCL injury may not heal but may not cause any problems. The ACL is the one ligament that no athlete wants to hear about. On the picture here, you can see the stump of the ACL. That's what happens when it tears. Now, you do see blood in there, but there's nothing going into that stump. So the first thing we do for an ACL tear is a prehab program. There are a lot of risks with ACL injuries, but one of the biggest or most common is stiffness after surgery, and that can be very difficult to get better from. So oftentimes we'll send our athletes to a prehab program to regain their motion. If you start with a stiff knee, you often get a stiff knee out after surgery. Now, the prehab also goes through and strengthens the muscles so that we can proceed faster with rehab after surgery. Now, in surgery, there are multiple graft choices. I tend to use a hamstring graft that comes from your own body because it heals quickly and doesn't interfere with your extensor mechanism. As you remember before, we were talking about how important the tendons are about the knee. Another common graft is bone patellar tendon bone, where we take actually out a piece of your tibia, the central portion of your patellar tendon, and then a piece of your patella or kneecap. That works great. You get bone-to-bone healing, but it does interfere with your extension of your knee. Some people will also use cadaveric graft. The advantage of that is that it doesn't affect any parts of you, but it can heal slower and it has other complicating factors. Many people will use that for revision surgery. Post-op rehab is critically important. That's where you get your motion back, your strength back, and getting back to your activities. Now, bracing is something that's interesting with ACLs. Initially, we will sometimes brace to help prevent initial injury, but after 6 months, your ACL that's been fixed is even stronger than the one that your native one on the other side. So technically, if you're worried about it, you put a brace on your opposite side, and of course we don't do that. So here are the before and after picture. We see the stump of the ACL on the left, and then on the right, you can see in the back, the PCL fibers going up to the right, and then on the left, the graft coming up through, and again, that's a hamstring graft. So prevention is a big topic, and it's something that we have on our webinar as well. Neuromuscular training includes plyometrics, balance, and technique. We can actually train the muscles of the knee to help protect the ACL. The second part of the training may facilitate neuromuscular adaptations. Basically, we're training the muscles to help stabilize the joint and actually have you learn how to land and jump and pivot differently, which will protect the ACL. Lastly, we have articular cartilage injury. So articular cartilage is a cartilage that's on the end of the bone, like the end of a chicken bone. It can get injured in a couple ways. It can be a direct blow, where you knock a piece of cartilage off, or it can be what arthritis is. On the left, we can see an arthritic knee. That's bone on bone. Again, something you don't want to hear, but happens quite commonly. On the right, there was an athlete that actually landed hard and knocked a piece of cartilage off, where the rest of the cartilage actually looks good. In this instance, we can actually repair the cartilage by coring out the bone and where the cartilage used to be, and then we put a plug of cartilage and bone in. Again, cartilage just doesn't heal very well. So oftentimes, if we can put it in associated with bone, the bone-to-bone heals, and then it helps hold the cartilage in place. And that's what we see here. So here the graft is dyed blue to help with sterilization, and then fits into that area, and we get bone-to-bone healing. And here's a before and after, where there was an isolated injury where the cartilage was good all around the defect, and then we were able to fill that with cartilage to make a more normal looking knee. So what's next? There are new things that are on the horizon, which we are working and researching even as we speak. PRP, or platelet-rich plasma, is where we take out blood from your body. We spin it down and get to a plasma layer that has healing factors in it. They circulate in your blood all the time, but they're fairly diffuse. If we can concentrate them down and then inject them into injured areas of your body, they can help things heal faster. And we see this a lot in chronic tendinitises. So here you can see a patellar tendinitis. We also see it with elbows, golfer's elbow, or tennis elbow. So what it does is it concentrates the healing factors and then puts them in an area that isn't healing very quickly. It's been around for a while, but unfortunately it's still not covered by insurance. We've heard a lot about stem cells recently, and stem cells are cells that are called pluripotent, meaning they can change into any cell in the body. We can get these cells to become cartilage cells, but we have a hard time getting them to stick in the joint. We can take them out of marrow cells in adults, or sometimes fat cells, and turn them into cartilage cells. Now currently we inject those into the knee, and they can help, but they don't necessarily stick. It may be because they reduce inflammation, but hopefully at some point we'll be able to regenerate cells and actually put them in to fix things like arthritis. Again, that is not covered by insurance. Subchondroplasty is something that I specialize in. What we found is in arthritis, you can get these small fractures in the bone, or microfractures, which cause pain. So if you have the same amount of cartilage damage but have these fractures, you tend to have a lot more pain than if you don't have these. So what I do there is I inject calcium into the bone, which fills up all the nooks and crannies and then hardens, gives it strength. It helps resolve pain. Again, arthritis is something that if you don't have pain, we don't do anything with. So if we want to get rid of the pain, we let you get back to your activities. An advantage of this is it is covered by insurance. So this is a problem that's only seen on MRI. So here you can see the bone is supposed to be a dark black or gray color. And you can see on the right side of the screen all that white, and then the dark black is actually where the fracture is, this little mini or micro fracture. This is what it looks like in the operating room. So you can see there's that meniscus that we talked about. I removed part of that, but then above it, instead of seeing a big cap of cartilage, you can see basically bone there. On the right, you can see where I put the cannula in, or basically a big needle into the bone, and then I inject the calcium through that into the bone. Again, it fills up those nooks and crannies, hardens, and gives it strength. This person actually needed it in all 4 parts of his knee. So there is hope with this, is that even bad arthritis can sometimes be treated without knee replacement. Here on the left, you can see where all that white is where I put the calcium in. And then on the right, you can actually pick out those holes where the cannula went in. And next up, my good friend Molly Woods, a head athletic trainer at Northern Kentucky University, will be talking about rehab, prehab, and what we do with these injuries.
Hi, my name is Molly Woods. I'm the head athletic trainer at Northern Kentucky University. I work for St. Elizabeth Sports Medicine and work in conjunction with OrthoCincy. Today we're going to talk about knee injury prevention. The number of related injuries in the emergency room is almost 1.5 million per year. That cost comes to almost $7.5 billion in medical insurance and work loss. Not only does osteoarthritis come with the elderly, but it also, when you have an injury, trauma, you are 3 to 6 times more likely to develop knee osteoarthritis and are diagnosed 10 years earlier than those without a history of an injury. We are going to use a multi-component prevention training program. We want to do this 2 to 3 times per week for approximately 15-20 minutes. Can help you reduce those injuries. It's not something that should take a long time, but we want a complete program. So we're going to work on the things I'll talk about today are flexibility, strength training, plyometrics, balance, nutrition, hydration, and recovery. So the first thing we're going to talk about is flexibility. There's 2 different kinds of flexibility. We're going to work on dynamic and static. The dynamic flexibility we're going to work on is the degree of which the joint can be moved by a muscle contraction. Usually performed before activity, so before walking, before running, before strength training. So some examples of this are Jumping jacks. If you can't do a jumping jack because of your knee injury or you're older or some other injury, you can just tap out to the side. We're gonna do knee hugs, just walking knee hugs where you hug your knee up into your chest gently. If you can't go as high as the student athlete I have performing it, that's okay too. The next is just swinging your leg back and forth. We're gonna go forward to your range of motion. It doesn't have to be at that high, and then we're gonna go side to side. Just moving the muscle, moving the hip, moving your lower extremity to your range of motion. The next one is scoops. You're gonna just walk, pull your heel up, toes up, and bend over and scoop kind of the air and then stand up. Trunk twist. Within your range of motion again, your lower body's gonna be stationary, and then we're gonna move on to arm swings. Backwards and forwards. These are hip hurdles. Forwards, you're just walking and raising your hip up to the side and bringing it to forward. And then you're gonna go backwards, step backwards, raise it up, and move it towards the back. It's pretty simple, should only take about 5 to 10 minutes working on that range of motion through movement. The next kind is static, just like the word, it's kind of a stationary stretching. It's the degree to which a joint can be moved passively to its endpoints. So we're gonna perform these after the activity. You're gonna hold the stretch for about 30 seconds. You need to repeat it 2 to 3 times and perform it twice daily. Research shows that you wanna do your static stretching for up to a minute at a time over a day in order to increase your flexibility. You should hold it to the point where you feel a good stretch, not pain. That's very important. Stretching should not hurt. It should not be painful. You just want a good stretch and just hold it there. Again, this is a little bit safer than dynamic stretching. So this is for the hamstring. The most important thing is keeping your chest up and moving forward. I'm gonna show you, that's bad form, where you're bending at the back. That's just stretching your back out. That's not really working your hamstrings. The next one is a quadricep stretch. You're just pulling your leg up, bending your knee and pulling it up and holding it. Don't do this where the knee is out to the side. You want to make sure that knee is nice and tight into your other knee. This is a hip flexor stretch where you just stand up and you just hold on and then lean back. That's going to stretch the front of your hip. This is a runner stretch, a calf stretch. You're going to do it with your knee straight and bent. Again, holding it for 20 to 30 seconds. And an IT band, you're gonna cross the foot in front of you and then bend to the opposite side. So dynamic stretching, again, like the video shows, good form is probably the most important part of flexibility, making sure that you're going through a slow range of motion and stopping at the endpoints that is safe and just a good stretch. Next, we're gonna talk about strength training. This is the ability to generate force against some resistance. So we want to start slow. We're not trying to injure ourselves with strength training and lifting too much weight at the beginning. So we're going to start with 2 sets of 10. We're going to progress to 3 sets of 10. And then once that becomes easy, we'll add some weight. This exercise is what we call a straight leg raise. The most important part here is that the leg stays straight. We don't want to bend in the knee. We just want it straight. We're going to do all 4 sides. So as you can see, she rolls onto one side and raises it up. Again, keeping that knee straight. And it's whatever your hip range of motion is. She'll lay on her stomach and raise it up off the table. This is a really good basic exercise to prevent knee injuries and build strength of your hip. She rolls on the other side. This one's a little more complicated. The top foot goes on front and then you raise it up off the table. If you can only raise it an inch or 2, that's okay too. The next exercise is a bridge. This is a super safe exercise. You're just going to bend your knees and raise up to a straight line and then lower. You can add difficulty by raising it up to just 1 foot. You can add a ball and squeeze squeeze in too, that which aren't in the video, but those can advance the exercise. This is a wall sit. Again, very safe, static. You're gonna look at her knees. They're not over her toes, so that's perfect. We're going to go down until your legs are parallel to the ground. These are calf raises. You're just gonna raise up onto your toe. If you need to hold on for balance, that's fine. Hold on to a chair, hold on to the wall. You're just raising up to your toes and then lowering yourself back down. Mini squats, you're lowering down to your range of motion. She's going pretty low. You don't have to go that low. You just wanna make sure your knees don't go over top of your toes, so you're not leaning forward. Mini lunges, all right? Same thing, she's just going on one foot, but I would recommend you're doing both feet. She's going forwards, she's going backwards, and now she'll go out to the side. The side one, the most important thing is that left leg of hers is staying straight. Also, we want to talk about core strength. So sit-ups, toe touches, Supermans, that's where you lay on your stomach and kind of raise your arms and your legs off the ground, hold it for a couple seconds, and planks. I'm sure most people have seen a plank where you're on your forearms and raise your body in a straight line. You don't have to start on the ground with these. If you need to, on the side of a chair, on the side of your couch, on your steps, your 3 or 4 steps, you're just holding yourself up in a straight line. Start there for 20 to 30 seconds, and then as you get stronger, you can lower yourself down to the ground. Plyometrics is the next part of our training program. That is strength training with speed. The idea is that the muscle switches from a stretch to a contraction in a short amount of time. This is very dynamic, and we need to be careful with this. It's very important. It's going to help us prevent injuries and prepare our body, so in case we have a fall, our bodies are used to moving like this. The advantages is it helps develop muscular control in a dynamic movement. We're going to start with just little line jumps, jumping forward and back, and then side to side. Very simple. If you can't do that, just step side to side, forward and back. These are called lateral bounds, where you're jumping 2 to 3 feet and landing on one leg and back. He'll then do a broad jump. Obviously, he's jumping pretty far. You can just do 1 foot, 1 foot or 2 feet. These are 90-90s, where you're just jumping and turning to the side on one side, to the right, and then to the left. And then we do what we call 180s, where he will turn all the way around and then jump all the way back. Again, these are advancing as we go along. Now he's just showing off here. These are box jumps. Obviously, most people are not Division I college athletes and aren't going to be able to jump up. Probably that's about 5 feet. And he couldn't even do it that time. But we're going to just do it once, once or twice, maybe 6 inches. We're just going to jump, find a step, find a stool, something like that, where we can jump up and land and then jump down. If you can only do 2 inches, 3 inches, and we're just going to build up from there. The next component of exercises that we're going to talk about is balance. It involves muscular, neurologic, and biomechanical information. The lack of balance may indicate a weakness in your muscular strength or kinesthetic awareness. We're going to start with flat ground. Usually I have my athletes who are balancing. We start flat ground, eyes open. Once they can do that for about 20 to 30 seconds, then we just have them close their eyes on a flat surface. It's amazing how much more difficult it is to balance with your eyes closed. Your brain has to figure out in space where your body is. When we have an injury, we have to retrain that. You can't rely on, when your eyes are open, you rely on objects in the room for space and for balance. When we close our eyes, we can't rely on those things in the room, and our body has to tell our brain where it is. So once one of my athletes gets really good at flat surfaces with their eyes closed, then we add in what's called an unstable surface, which you can see in these pictures are the mattress pad. We call it the AirX pad. And we have them start again with their eyes open because now that the floor is unstable. Once they get good at that, then we go right to eyes closed. You'll see this is one of my soccer players, and I toss a ball to him, whether I have him kick it, have him head it. And he's been doing rehab for a long time, so he's pretty good at this. You can also do this on a stable surface. Here we're introducing strength training, so we're doing what's called RDLs. We're making him change his level of balance. We're having him do RDLs where he goes down and he touches the floor while he balances, and then he comes back up. As a college athlete, soccer player, he's gonna have to have contact. So a lot of times I'll have someone, one of his teammates or myself, tap him while he's on that uneven surface. Again, making his brain understand where his knee and his ankle are in space. Our next 3 parts of our prevention program are more total body. So we're gonna talk about nutrition. People need to understand nutrition, and there's so many myths out there, whether it's low carbs, high protein, paleo, macros. There's a lot of confusion out there. Most people, what I've found, most of my student athletes, they're eating calories, but they're not eating quality calories. They're eating junk food, they're eating, fast food, fried food. You need to have carbohydrates, you need to have protein, and you need to have fats. What you choose is up to you. But you need to have all 3 to help prevent injuries. Your body needs all 3 parts: carbohydrates, proteins, and fats. When an injury occurs, your metabolic rate can increase 15 to 20%, secondary to your body's using more energy to heal. When this happens, you need to increase your amount of protein just a little bit to help build that muscle and decrease the inflammation response to that injury. You want to avoid nutrient deficits. So again, making sure you're getting quality calories. You want to avoid alcohol. It impairs your wound healing and will prolong the process of your body trying to make the injury go away. Hydration is another key to injury prevention. Water makes up 50 to 60% of your body. It helps bring nutrients to ligaments, tendons, cartilage, and flushes waste from the system and lubricates your joints. With optimal hydration levels, benefits include maintaining athletic performance, maximizing heat thermoregulatory system, and facilitating recovery from exercise. All of the above can be compromised with just 2% decrease in hydration. And dehydration leads to increased stress on the body system during exercise. Unfortunately, thirst starts at 2% fluid loss of dehydration, which means when you're thirsty, you're already dehydrated. Water is enough for activities up to 60 minutes. Electrolytes, which are in Gatorades and that kind of stuff, if you're gonna be with prolonged activity and heat. Recovery, it's the most important part of injury prevention. It's an important aspect of resting is muscle growth and energy replenishment, physically and mentally. Your body needs rest, it needs sleep. 7 to 8 hours, the body uses this time to heal and make you stronger. If you must do something on your days off, do active recovery. Learn to cross-train, walk, swim, an easy elliptical, foam roll, band stretch. Those are all activities that can help improve your active recovery. Listen to your body. It will tell you when enough is enough. Your body needs rest. So in conclusion, we need to use a multi-component strategy for injury prevention. For younger athletes, I recommend educating their coaches, their parents on how to do this. It needs to happen over time. This is not something that's going to happen within a week or 2 weeks. This is something that you need to do every day to gain prevention. Good nutrition, that's always something everyone strives for. Stay hydrated, at least your body weight in ounces of fluids, and rest. All athletes need it no matter their age or activity. Thank you for joining us today. I'm an athletic trainer with Northern Kentucky University, and now we'll get into the question and answer part of the program.